So, methadone and buprenorphine. A lot of folks that I work with say, well, she's never going to get off of it. Who cares? The point is not to get off of opioids. The point is to not die. That's the point. And methadone and buprenorphine are both really strong binders to those receptors in our brains. So a lot of times if folks use other drugs on top of it, there won't be as much of a rush effect. So it really can help decrease cravings. We know that people who are on methadone and buprenorphine, not all of them, but a good proportion of them continue to use illicit drugs. And that doesn't mean that they should be taken off their methadone and buprenorphine. They tend to continue to use, but they also continue to use dramatically less and to decrease their use as time goes on. The other thing is in pregnancy and labor, if you are on methadone, that is not pain control. And I see this in my work a lot. People are always saying, oh, well, you don't need other medications because you're on all that methadone. No, that's what they need to feel normal. You need to give people more medication on top of that for labor, especially if they have a C-section. Drug seeking is a term that I hate because every time it's applied to somebody, they're seeking drugs that are usually appropriate. I've had countless people go in to get abscesses lanced, which, if you know, that's an incredibly painful procedure, and they're told they can't have pain medication because they're drug seeking. Yeah, they're seeking appropriate drugs for their appropriate health condition. So that's a really, really important thing to remember. Another thing that is a benefit of opioid agonist treatment is decreased infection risk. So even if you're still injecting, if you're injecting less, that's less chances of getting one of those infections that can affect your pregnancy and your baby. Improved stability in your life. Getting money to buy drugs and finding drugs and buying drugs and using drugs takes up a lot of time for a lot of folks. And so just being able to have that stability and not have to worry about that can be transformative for a lot of these lives. Buprenorphine is probably better than methadone for pregnancy, for neonatal outcomes. We have a few studies in the last 10 years or so showing slightly decreased, but still statistically significant length of stay in the hospital, length of treatment for babies that were exposed to buprenorphine rather than methadone. Now, if somebody's not on any kind of treatment and they become pregnant, we're going to start them on methadone rather than buprenorphine. Because methadone is a straight agonist, so that means it always turns on the receptors in our brains. Buprenorphine is a mixed agonist-antagonist, so that means sometimes it turns them on, sometimes it turns them off, sometimes it just blocks them. And so it can throw somebody who is dependent on opioids into withdrawal, which we don't want. And as with all things that are better, buprenorphine is much easier to access for people with private health insurance and money and cars and homes. And so you'll end up seeing a lot of those disparities with who gets buprenorphine and